talking about potassium, needless to say at this point, we all know that it's the major cation found inside of the cells. And just a brief review that concentration will be maintained by sodium-potassium pump. The regulation of the the regulation of potassium can be related to insulin levels, and also potassium will regulate intracellular electrical neutrality in relation to sodium and proton or acidity. So why we need potassium? Because it's needed for conduction of nerve impulses to maintain normal cardiac contraction and rhythms, and also skeletal and smooth, let's say, GI muscle contraction. All of these governed by potassium. That's why it's important to provide a concentration of potassium that's fairly small segment, in very small interval, and we have to maintain it. Otherwise, it may result in several profound dysfunctions, and to name the most profound is cardiac arrhythmias and even death. Potassium levels can be affected by changes in pH, and that may affect potassium balance. So when hydrogen ions will accumulate in intracellular fluid during acidosis, when body is acidotic, potassium will go out or shift out from inside of the cell to balance the cations across the membrane. So again, this will be a consequence of acidosis. So aldosterone, insulin, and catecholamines will regulate or influence potassium levels. So to talk about insulin, this is very important concept, and sometimes it's overlooked because we talk about insulin as an agent to treat diabetes. However, this is an important drug to treat potassium dysfunction. Insulin will increase the permeability of cells to potassium, as well as magnesium and phosphate, of course, but we are talking about potassium here. The effect of potassium here is the one that's clinically important, the one we concern. So what happens? Insulin will activate the sodium-potassium ATPase in many cells, and it will allow an influx of potassium into the cell. So think about it. We all know that insulin is a dangerous drug or high-risk medication, but we're always thinking about hypoglycemia. On the other hand, injection of excessive amount of insulin may be deadly because of its ability to decrease plasma concentration of potassium. On the other hand, this may be an agent to treat excessive potassium concentration. Hyperkalemia is when the level of potassium drops below 3.5 milliequivalents in a liter, and we can name several causes of this. So again, intake of potassium reduced. Again, increased potassium entry into the cells, and again, increased potassium loss. So when we're talking about electrolytes, there are two themes you hear over and over again. It's the loss when we talking about some type of hyperkalemia or hyponatremia, intake, so you don't get enough. And on the other hand, potassium is quite unique because increased potassium entry into the cell can, of course, result in hyperkalemia. What will happen if we're having low potassium level? The cellular membrane hyperpolarizes, and it will cause the neuromuscular excitability decrease. So when we're saying neuromuscular excitability decreased, we mean that the patient will have the weakness of skeletal muscle, and if they are weak, they cannot move it, and if they have been exposed to hyperkalemia for a long time, they will have smooth muscle atrophy because they don't move it. And the most urgent one, in this case hyperkalemia, smooth muscle atrophy will take a long time to develop, right? But what will develop right away or fairly fast is cardiac dysrhythmias. Hyperkalemia, on the other hand, is potassium excess, more than 5.5 milliequivalent a liter. So from 3.5 to 5.5, this is your normal range. Again, depends on the lab, 3.5 to 5.0, 5.1, 5.2. Again, this is all relative. It will be giving you a range. When we're talking about lab values, we have to consider the lab ranges your lab entity you choose for your results provides you with their norms, but also you may consider the references you learned in your education. Hyperkalemia is relatively rare deficit because we all remember working in the hospital. We'll pump the patients with these bags with added potassium, or even you can give potassium injections, of course not concentrated, or by injection I mean intravenous drips. And but treating hyperkalemia is fairly rare event in the hospital setting, but some of us did treat it, yeah. And what's causing this? So again, let's think about shifts. Let's think about shifts from, so shift from intracellular fluid will occur to extracellular for one or the other reason. Okay, potassium isn't excreted enough from renal. Oh, and again, insulin comes to play, and insulin deficiency can cause this. Cell trauma, cells burst and release lots of potassium into intravascular space, circulation. And one of the fairly common potassium level increase sources is either potassium poisoning, or when patient for one or the other reason takes excessive potassium supplement. And this is, we are entering into a completely different venue when patient forgets, or it can be intentional poisoning with potassium. Also, also another option is your patient will have hyperkalemia. It's part of the lethal injection, or at least in some states the artificially induced hyperkalemia, and will result, of course, in cardiac arrest. Hyperkalemia, when it's mild, it will result in hyperpolarization of the cellular membrane. And again, if we hyperpolarized it, then our neuromuscular irritation or irritability will increase. So patient will complain of tingling of lips or fingers. They sometimes may describe it as paresthesia. but it's really tingling sensation. Patient may be restless, have cramping, and also may have cramping in their abdomen or is intestinal cramping, increased peristalsis, and diarrhea. So hopefully we can correct all of this, but when we enter into a severe state of hyperkalemia, the cells will not be able to repolarize, resulting in muscle weakness. So from irritability increased, we are losing the ability to repolarize, and we're losing muscle tone, and we are getting into a state of flaccid paralysis and cardiac arrest. So this is what I was saying previously. Excessive potassium can certainly be deadly and can certainly be used as a lethal injection. But as nurses, we prefer to treat the abnormal conditions, not to induce them. So what will we do for treatment? Calcium gluconate can restore the neuromuscular irritability when the potassium levels are high. But this is some type of a little bit temporary solution, because you're still not dealing with serum potassium levels, especially if it's the decreased exertion takes place, decreased renal exertion, then we just putting a little band-aids on the problem. How to deal with it like profoundly and just fix it for good, at least for a long time. So we can actually administer glucose if patient can produce their own insulin. If we administer glucose, patient will have a boost in insulin, which will cause the movement of potassium to intracellular space. But if you kind of in doubt that patient can produce insulin, or you know that your patient has diabetes, especially type 1, you know they don't produce their own, so you can give just insulin, and which will facilitate cellular entry of potassium. Of course, at that point, you have to monitor the glucose level and not to induce profound hypoglycemia. Another reason, as I was talking, the correlation between potassium and hydrogen ion concentration, but another reason of this can be, of hyperkalemia, can be acidosis related. So to fix our acidosis, we'll proceed with administering bicarb, or bicarb that everyone says in the hospital, but it's sodium bicarbonate, to correct metabolic acidosis and lower at the same time sodium potassium concentration. One of the most common options you will see done, it's administration of cation exchange resins, and it's famous kioxalate with exchange sodium for potassium in the intestine, and it can be effective. Kioxalate can be given orally and also rectally to produce these effects, but it's a relatively well researched method, and it's most of the time it's very effective.